On today's episode of the 340 Banter podcast, Chelsea and I are joined by Donovan Smith, the CEO of Wayne Community Health Centers. Donovan's going to be talking to us about the MFP effectuation and all the challenges his health center has faced along the way and what they're seeing to this point.
So we are about 3 months into the IRA Maximum Fair Price effectuation, or ineffectuation in some cases, unfortunately. Donovan, can you share a little bit about your organization and your experience with the MFP pricing so far?
Yeah, absolutely. So we are a community health center out in the south central portion of the state of Utah. We service about 4,500 patients within our organization. We've got only 2,500 individuals that live in the county of Wayne in Utah. And so we're a very rural organization. We cover an area about 7,500 square miles.
Holy cow.
That's large.
It's a very large area for a service area. And so we're very remote
With
where
a
we're
very
at.
small number of people for that area.
Correct. Yeah. We've got 3 operational sites. One is only operational for about a half a day per week. It would be more of your doc in a box type of a thing where we actually send providers to the remote site, and then they will then administer medications right out of a box for them, and then they bring that back. And it's a kind of the old school type of medicine. But the MFP process for us has really been a challenge for a lot of our patients that we serve within our organization, from a standpoint of, what can we do? We found ourselves in a unique position where we're kind of behind the 8 ball as we've looked at our claims, as we've kind of started off on this process. My staff in the pharmacy is very diligent. They're very good and very precise in being able to know what it is that we're doing. And
As pharmacists often are.
yes, we're all a little bit on that side of the spectrum, which is a good thing, I think. Because we're so meticulous. But with that, as we started through this process, we've made sure that all of our claims have been clean, that we're transmitting all of the necessary SCC codes.
Even though that's voluntary, that's
right.
You're doing what you can.
We want to. We want to be those good stewards, that we're setting the example of making sure that we're sending out clean claims. But what we found out is that as we were sending out these claims, we would get a rejection going, well, we're not going to pay you your MFP rebate because you're attributed to a 340B covered entity. And to put that into perspective, our pharmacy operates a dual physical inventory. So we have medications that are on our shelves that may sit on our shelf. It's really kind of dependent upon whether a person comes to our pharmacy and with a prescription.
And I'm guessing in your remote area, you probably have a lot of people that come to your pharmacies who are not patients of your health center.
Absolutely. Yeah. We see a tremendous amount of individuals from all over the world, for that matter, being in a high tourist area. And so, with that dual model, as we're may order a product in and stock that on our shelf, we have to wait for that individual to come in with the prescription. So then at that point in time that we're dispensing. So when we have submitted these claims through the MFP process, like I said, we submit clean claims and we audit those claims meticulously. And so that we're making sure that they are actually going through correctly. But what we've found is that when we have an individual who's of Medicare age and then we submit those claims, they are turning and saying, hey, you know what? You don't deserve that rebate. And so now we're putting out, we're buying the medications at the the most expensive rate there is at WAC, that wholesale acquisition cost, which is just even above what normally our retail price would be. And now we're having to wait to be made whole. Well,
and in some cases being told you're not going to be made whole because there's not, the back end doesn't have all the information, and they're interpreting that as a 340B eligible claim, even though it is not. You don't have an established relationship with the health center with that patient, just within the pharmacy.
Exactly. And being an open door pharmacy, we take prescriptions from all over from our patients. They generally, we've got a high usage of our health center within our area just because of our location. We're being the only medical facility for 65 miles.
Wow.
I heard the term that they consider anything that's greater than 10 miles would be considered a pharmacy desert. And, if you compare that to the Antarctic desert, then that would mean that we are globally, we have our own pharmacy planet.
I was going to say a pharmacy wasteland.
Yeah, but so, our patients travel to see specialists. They travel to see other maybe physicians outside of our area, but they are still bringing those prescriptions to us in the hopes that we can fill those prescriptions. And, so we're using products that are not purchased under the 340B program to dispense those prescriptions. And then for somebody to come back and say, hey, well, you're doing the right thing, but we're not going to make you whole on the back end. That's really kind of a challenge for us.
It's got to be frustrating because you're taking money out of our scarce federal resources, and that's what 340B was there to help. And you're helping these patients who you cannot use 340B on, and you're not getting paid even what you paid for the drug. And it's taking funds away from your other safety net services. And that's difficult for any health center.
Yeah, it's really a challenge. So my pharmacy director came in to me about a month into the process and goes, we've not received any money. We're not getting any of the rebates coming back. I'm like, well, what do you mean? I says that this was supposed to be you submit the claim, you do it correctly, you get your rebate, and you're to be made whole.
And just as a point of clarification, because I think this is a misconception in submitting claims, it's not like we're going through a separate process for this, submitting them to like the 340B ESP process for manufacturer restrictions. This is just billing claims in the pharmacy. And when they hit the switch to
it should
pay
be
insurance,
automatic that you get your refund.
Yeah, it goes to the Medicare Transaction Facilitator, the MTF, and that's where that determination begins. It then can go over to the Beacon MFP platform, and that's
a
where
lot
the
of
340B,
M abbreviations.
Yes, so
yeah,
many.
Goodness gracious.
So that submission is just your standard billing process, and as you said, you're doing that voluntary SCC 20 code to identify the 340B claims, but there's no identifier for a non-340B claim. So the lack of the modifier should indicate that it is not a 340B claim, but ultimately, because the Beacon MFP platform is manufacturers are utilizing a number of different mechanisms to identify 340B claims through that platform. It's not just the presence or absence of that modifier. So it could be if your pharmacy is associated with a covered entity, or it is listed on OPACE as a contract pharmacy, or has a history of 340B purchases. There's a number of ways that that's being identified. And that's really ultimately how the claims are being, the claims or requests for refund or rebate are being denied for 340B. And in your case, you're saying you have a large number of prescriptions that are not 340B eligible, where you're not getting paid the rebate or refund because they have been assessed to be 340B.
Exactly. Just by mere of association that we are a 340B organization because we're a health center. But that doesn't account for all of my patients. 30% of my patients, or 30% are considered ineligible for that 340B program because they are seeing.
And that's really high for a health center. I mean, most health center pharmacies, it's less than probably 10% are non-health center patients. But when you're in those remote areas, it's sometimes the only choice.
Yeah. And so, when my pharmacy director told me about this, I'm like, okay, well, let's just kind of, I know this whole process is new and we wanted to be patient with the process, understanding that if it was us implementing a new process, we would hope that we could get through this. And so I says, let's follow the channels and kind of work this program. And so we did. We went through the GFI process through Beacon and saying, hey, these prescriptions aren't 340B. These are our Medicare patients that we do deserve that Medicare rebate on. And so we ended up receiving notification back, hey, your claims aren't eligible for an MFP rebate. And we're so sorry because they're 340B. And then they go, well, what we would like is that we want your dispensations of the 340B product that you've ordered from this wholesaler on this date back in November. And that's like, well, that bottle's still sitting on my shelf.
Yeah.
So because I've not had a patient on that, I stock the product so that I have it available for my patients if in the event that I receive a prescription, but it was sitting on my shelf. And I'm like, well, how do I provide a dispensation for a product that I've never dispensed yet? So as that bottle's sitting on my shelf, and so we responded back going, okay, well, this product's sitting on my shelf. And at this point in time, we can't provide any dispensations for that product.
Yeah.
For that reason, it's still sitting on my shelf. And so how do I prove?
You can't prove a negative.
Yeah.
It's not possible.
We learned that in
We're
pharmacy
kinda
school.
Stuck, and so we submitted that information into them, and we got a secondary response going, we're sorry, but you still need to provide that dispensation records. Otherwise, we're not going to be able to provide you that rebate. I'm like, well, this doesn't make a whole lot of sense. So we actually then escalated this, and we filed a CMS claim for these same claims. And unfortunately, we received a response back from them with that nice pat on the head saying, thank you for your claims. We appreciate you notifying us of this. And that was the end of it. Please refer to Beacon.
It's unfortunate.
So we've kind of gone full circle now. And
now they're sending us back. That's the process we're supposed to follow, is the good faith inquiry through Beacon. And then the Inflation Reduction Act said at that point, then you can move on to filing a complaint through the Medicare transaction facilitator, but they're pointing you back to the original place, which is frustrating.
One of the bigger challenges is that the way that the language was written for the maximum fair price negotiations is that the manufacturers do not have to, they're not subject to paying both the 340B discount and the refund or rebate on the back end for the same prescription, not too dissimilar from what we see with Medicaid prescriptions. But the language around this puts the responsibility squarely on the manufacturer, and the way that this is being enacted or implemented so far has very much put the responsibility on the covered entity, and especially challenging when the responsibility is to prove a negative or to demonstrate claims that are tied to an invoice or tied to a purchased product that is part of a physical inventory model that doesn't have claims associated with it yet. So it understanding that the challenge that the manufacturers don't have all the information to be able to tie things out at a prescription level basis or an invoice level basis, but that the absence of their information has now become the covered entities challenge, and covered entities that have such limited resources to begin with are now being forced to, what is the judge in Maine that ruled on the last case about the rebate model said, like, float an interest-free loan for manufacturers, which is what's happening, which brings me to operationally, what does this look like for you? How has this impacted your cash flow for an organization or your cost of drugs, or ultimately the care you've been able to provide to your patients?
That's been a challenge for us. I mean, we are a very small facility, one of the smaller ones in the nation, and even $1,000, which may not seem like a lot to an organization, means a lot to us. And so when you figure that one prescription on average, when you go through the myriad of medications, or at least the ones that we're currently dispensing, it's about $750 to $800 per prescription. It starts to add up very quickly. And now I'm finding myself floating a loan because I paid the full price, and now
And the payer reimbursed you at this lower
at the low rate,
Yes.
which doesn't cover my costs. So now I've got to hold that bag essentially of debt for an organization in the efforts of us trying to get that money back, which we haven't really been successful with.
And you said about 30% of your patients at your pharmacy are not 340B eligible, or prescriptions that you fill are not 340B eligible. And there's a subset of that are these 10 drugs that are negotiated. But for all of those, you're then operating at a loss, and a fairly significant loss. We're $700 to $800 per prescription. And now we are 3 months into that process. So those have compounded over time, I'm sure.
And made even worse by the fact that we're not even getting fair dispensing fees.
Exactly.
What we've seen is less than $1 dispensing fee. And it was, there was a memo from CMS to the plans out during August that said they were expected to pay a fair dispensing fee above the cost of the drug itself. And we're seeing less than $1 on average across the country. So we've been working with CMS on that, but we haven't got any headway yet on what that looks like getting that corrected.
Yeah. And, it's a challenge, when you look at your budget and you go, okay, well, how much of this loss can I ultimately take? And really, and thank heavens that this is only just 10 drugs. I mean, but I do fear as we move forward, because this is going to be 20 drugs,
Additive,
and then 35 drugs, and it just keeps more and more and more and more. But, I look at it from an operational standpoint and going, okay, I'm taking these financial hits, and it's becoming unsustainable. And so we've started the discussions internally of how can we survive, and that's really what it comes to, is how can we survive and make this work for our organization. So I'm going to give you a little anecdote story. My father-in-law, who I've been the pharmacist, so being a pharmacist and then transitioning into the CEO position, I've always dispensed his medications. It makes sense, for the last 20 years. And 91-year-old gentleman, he's on one of these in particular medications, but the decisions that we're talking within our leadership is, can we continue to operate in this manner where we're buying these medications at such a high price and then not receiving back the necessary payments?
Yeah.
We can't continue. And my 91-year-old father-in-law is on that list. So this strikes me personally.
Yeah.
Within my own family, let alone the patients that I'm currently, trying to treat at our health center in this very remote, location.
And if you tell them that you can't fill those prescriptions, you said 65 miles is the
correct
next
so
pharmacy?
Now I'm asking an individual, hey, I'm so sorry, I can't fill your prescription. You're going to have to travel over a mountain pass of 9,000 feet. And then during the winter times, those mountains sometimes will close down.
And for a 91-year-old.
And you're going to have to fill that prescription at the nearest retail pharmacy, because I can't do it, because I can't take the loss anymore. And that's really the discussions. And that's the turning point where we're at. We're here in March. We're almost to that first quarter. And we're feeling the pinch, and it's sad to think that the whole premises of the 340B program was designed really to kind of open up opportunities for us to allow to treat more patients and provide more services and stretch our resources as far as possible. But now it's become that hindrance of that it's challenging us to do just that, which is sad.
It is.
And like I said, my 91-year-old father-in-law doesn't deserve that. None of my patients, my patients treat deserve this.
Yeah.
But at the end of the day, if I don't do something, then
You're not going to be able to serve any of your patients.
Exactly. Where do I start making those cuts? And that really is the true story. And we were told, well, this is a one-off. This is a one-off, and I dare to disagree with that term, because I get
I'm
covered
talking to
into
health
these
centers all over the country
Yes,
that are in the same boat.
and they're calling me, going, "Hey, I know that you talk in the 340B world, and you've been there. Is there any assistance that you can give me?" And I'm like, "I'm so sorry." I says, "I'm in that same boat right now." And it's unfortunate, though, to see that those organizations that are trying to provide these charitable care or helping the low income, the underserved, the uninsured, the most vulnerable populations as a safety net provider, but we're struggling just to make ends meet when it comes to these pharmacy programs like this. And it's really kind of sad.
Well, to try to end our discussion on a slightly more positive note, let's just kind of touch base on the efforts that are being made to help improve this process that we know about. I know we've got folks reaching out to CMS to be able to provide context and stories such as yours to say, here's how this isn't working, but also offering up possible solutions for how this could work better. Working with the Beacon MFP platform, suggesting an easier way to identify a claim as not 340B, because they have that mechanism to identify a claim as 340B, and potentially just educating more folks about physical inventory models such as yours, where really the purchase doesn't necessarily align with a dispense right away. You have the purchase and it can sit on your shelves for a little while before you actually do dispense it. We've got folks talking about the neutral clearinghouse, claims clearinghouse, that could potentially also be used for the deduplication. That's not what it's being built for right now.
It's for the inflationary penalties as part of the Inflation Reduction Act. So if we can take that side of it and apply it to this, two birds with one stone.
Yeah. So none of that, unfortunately, helps us right in this moment. But I think that stories like yours are important to help continue to drive these efforts and advocacy for solutions that would work better for all parties involved.
And I think what I would say is, for covered entities in this situation, contact CMS, contact Beacon, make sure that you're making that effort to tell the story. I know it's frustrating and we're all taxed as far as time, but I think it's important that CMS gets that feedback so they can make changes, because it's not just 340B that's being hurt through this. It's the independent pharmacy community. It's a big change to the industry as a whole. So I think there's a potential to make some positive change.
And I'm a optimist at heart. I always want to look for that rainbow in the distance. And I think, we may be seeing some rainy skies right now, but I do think that eventually things can get worked out. We just need to be diligent with our record keeping. We need to make sure that we're following and reporting and doing everything that we're supposed to be doing. Because ultimately, at the end of the day, I think that this will get worked out. I just hope it works out sooner rather than later, because, we definitely need that. But
yeah. Thanks so much for joining us today, Donovan. Really
Absolutely.
Appreciate it.
Thanks for having me. I
Thank you.
appreciate the opportunity.
Thank you for listening to 340 Banter. This podcast is produced by Grit and Gravel, your partners in marketing strategy and success.